Mic check, testing, 1, 2. Mic check, 1, 2. Testing, 1, 2, 3. Mic check.
Good morning, and thanks everybody for coming. Welcome to the Florida's Governor's Mansion. I'm proud to be joined by our First Lady, as well as so many accomplished members of the Florida Cancer Connect Collaborative. And I don't think that there's been anyone in Florida whose life has not been impacted in some way by cancer, either personally, friends, family. It's something that's unfortunately been a major part of so many people's lives, including our families with what Casey went through a couple years ago. So we've partially because of going through that, but then also partially because it's the right thing to do. We've worked really hard to be able to advance the ball forward when it comes to cancer research and cancer treatment. Under the First Lady's leadership, the Cancer Connect Collaborative has broken down long-standing silos between researchers, cancer facilities, and medical providers to improve cancer research and treatment. In March of last year, Florida became the first state in the nation to collect cancer recurrence data. Before the initiative, there was no population-level data system that monitored cancer recurrence in any state. And so we are now on a path to bringing visibility to recurrence rates in Florida. That alone is going to help doctors make new breakthroughs. We have put our money where our mouth is when it comes to these initiatives. Last year, we invested $190 million in cancer research funding, including $20 million to establish the Florida Cancer Innovation Fund. And this year, we seek to do even more. In my budget recommendations for the upcoming fiscal year, we included more than $232 million for cancer research, including $60 million for the Florida Cancer Innovation Fund and $127.5 million for the First Lady's Cancer Research Program. So we know that this is something that is important to so many people throughout our state and really throughout our country. With today's announcement, we are bolstering state-of-the-art research to detect and fight cancer. I'm just here as the window dressing and to kind of open it up, but I'm going to turn over the run of show to Florida's First Lady, and then they'll commence with the roundtable discussion. So thanks everybody for coming. And happy Valentine's Day.
Did not plan it on Valentine's Day. It just happened to happen on today. So listen, you know, it's an amazing thing was 2 years ago, pretty much around this time, I was making Valentine's Day cards for our kids. And that was because I wanted to make sure that they had something to open because I was going to be getting surgery at that time for cancer. And now you fast forward to today, 2 years later, and I'm up at 5 o'clock in the morning making nearly 100 Valentine's Day cards because, of course, I had to have some for first grade, for pre-K, for kindergarten. So to really say that I've come a long way in 2 years, I really have. It's a testament to people in this room. It's a testament to the governor, who throughout the entire process, I mean, I had great doctors, oncologists, plastic surgeons. They know who they are. I can never tell them how much I thank them for everything that they did to save my life. But the governor had to live with me. And I'm sure that wasn't easy at times, especially when we had a 4, 3, and a 1-year-old running around the house. And so for him to be able to support me, but also to give me hope throughout the process, I mean, as you all well know, he understands and analyzes data. He reads it. He was giving me a no BS assessment of what I was facing, to have that strength to be there with me through everything, all while taking care of small children. It meant a lot. So I don't think it's a coincidence. It wasn't planned that this was on Valentine's Day, but here we are. So listen, it has been a journey, right? And you can talk to Dr. Diaz, who he is a cancer survivor now of, 8 years, 9 years. And you have a choice when you go through something like this. And one of the first things that I wanted to do was run into a hole and hide, or a closet. I never wanted to talk about the word cancer. As a matter of fact, I didn't even really refer to it as cancer. You don't even like saying the word. But, you know, I had a choice, particularly in the unique position that I am as First Lady. It is not about me. It is about, I have the opportunity with this title for the next 3 years to get people far smarter than me into a room to be able to make a difference. I had learned things along the way, but man, I'll tell you what, having this position as First Lady, you got to get into the arena. You got to fight. You can't be a potted plant on the side, you know, watching life pass you by. You got to be able to make a difference. And so with humility, I had the unique opportunity to be able, as First Lady, to start the Cancer Collaborative. And basically, this was something that was really, the governor had talked about in a totally separate event that we had did in 2019, right after he was elected. He said something that really resonated with me, and that was, we were doing a mental health roundtable in this room, and we had members of the legislature, we had members of the community, we had different stakeholders, and it was about, like I said, mental health. And he said something very profound at the time. He said, I don't want you guys to work in silos. I want you to collaborate. I want you to communicate. I want to talk about best outcomes. And man, that resonated with me for now the next 5 years. And that was really the premise under which we wanted to found the Cancer Collaborative. How do we work together better to maximize taxpayer dollars, to drive outcomes, to do more, to be able to save more lives, to help people, and to give people hope? And so here we are. And we really started the collaborative around 5 main points, one of which is data. We realized, Secretary Wida, that there's a 2-year lag when we're getting a lot of the information when someone presents with a cancer diagnosis and when it's actually being reported. And how do we use what we know faster to be able to make a difference? We need to know, are there higher reoccurrence rates? Are there more aggressive cancers? Are we seeing this now more than we had been before? And if so, why? Why are cancers now skewing younger? We need the data to keep up with innovation. We need to know what's going on. So we have to have a good reporting system. So they're tasked with how do we do a better job with the data. Best practices. This is something that I saw just anecdotally being a cancer patient. You know, if hospital system X has a really great technology or procedure or technique and hospital Y doesn't know about it, we need to tear down the walls of the silo and the profit models to make sure that Hospital X can communicate with Hospital Y and say, you know what, it really works. I'm helping a lot of people. I'm saving a lot of lives. This is something that we have to, it really feels like that when you look in the headlines and you turn on the news, I mean, we are at war with cancer. Everybody is being diagnosed, it seems like, with some form of cancer almost every day. And so therefore, we have to make sure this isn't about competitive advantages. This is about what we can do to help people survive, help people detect earlier, get better practices with less side effects, and all of these things. And so we've got to make sure we do best practices across the board, across the state. Florida's leading, and then we're going to have the nation obviously follow a lot of what Florida's doing. Funding is a big thing. Representative Garrison will talk to you about this. We want to make sure we appropriated, they did, $140 million. Let's get an ROI, a return on our investment. It is not okay to sit here and do a press conference and say, aren't we so great that we're allocating $140 million and we're recommending more. It doesn't mean anything if there aren't outcomes associated with what you're utilizing from the taxpayer. So we have to make sure that we're holding ourselves accountable. Where is the money going? And is it saving lives and helping people? Honesty. This is another one of the tenets of the collaborative. When I was meeting with some of my cancer docs, I would ask them, you know, do we really know, like, how did I get cancer? Like, I had never had a history of breast cancer. I didn't have the BRCA genes. I thought I was healthy. I thought I exercised. And here I am. And I would ask some of them, I would say, do we know? And they're like, yeah, we do know a lot of what causes it. Clearly the smoking. I don't smoke, but clearly there are things that you can do that contribute it. Well, I'll tell you what. We need to communicate everything that we know about what causes cancer to the people. No partisan anything, no agenda, nothing. I don't want to see somebody promoting something because they want to try to move a product. I want to know what causes it, what can we do to communicate to the people of the state and this country so they can make the decisions to protect themselves and their families. And so that's another tenet. And the last is innovation. Meeting with a lot of folks, there are a lot of really great technologies. Are there barriers to entry? Are there a lot of red tape and a lot of bureaucracy? Are there things that are happening that are preventing these from getting out to the hospitals and getting to people? And if so, what are they and how do you reduce it? And how do you fund that and how do you look at it? So that leads us to the announcement today, which is very exciting. So of the $140 million, $20 million has gone out the door to 30 different recipients in our Cancer Innovation Fund. And we started this because traditionally in Florida, a lot of the money, all of the money, that was appropriated would go to nationally accredited cancer institutes. But if you look, the majority of the cancers in the state of Florida are treated exterior of the NCIs. So we wanted to make sure that whatever technology, innovations, best practices, what have you, across the state of Florida, they have funds to be able to utilize that, to then bring into the conversation and the discourse, to be able to have opportunities, to be able to make a difference. So we're doing $20 million in the Innovation Fund to 30 different recipients from 16 different institutions. And that leads me now to 3 of the recipients who are here to talk a little bit about their grant. And is that me or you, Secretary? I don't know. I kept moving back a little bit. I don't know if you noticed that I was trying, because don't you hate it when the thing goes off and then everybody's ears get blown out? Okay, so Dr. Panetta, Nicholas Panetta, who is now the chair of the Department of Plastic Surgery at USF, I wanted him to come up because he has a really novel procedure that he's tapped into, talking about, complications after breast cancer surgery, specifically with the lymphatic system, because there's a lot of adverse things that can happen as a result of the surgery. And so he's really helping patients and women live lives without having to worry about a lot of these ramifications. So, Dr. Panetta. Sure.
How close can we get here? I'm not sure. So, good morning, everyone. I just first and foremost wanted to thank the governor and the First Lady for really this fantastic opportunity and empowering researchers and clinicians such as myself to study new technologies and techniques such as the one that is specific to my practice in a way that wasn't really previously possible, right? And so that's certainly going to have a positive impact on the lives of Floridians afflicted with this, with cancer. And I think an important thing, especially that the Cancer Innovation Fund is doing, is it's bridging a gap. So, as we all know, the hardest part of any project is just to act, to start. I always tell the residents and everything that the hardest part of anything they do when they're writing a paper, doing something, is writing the title page, right? Just to get started. So I think what we found as part of the work done by this collaborative, especially, is that Florida's full of a bunch of really, really bright people with a bunch of inertia ready to act, but they don't have the resources required to kind of engage in that. And I think that these funds have really worked to bridge that gap early on, and I think the potential is really unlimited to harness what the First Lady was saying, all those researchers across the state that have really good ideas regarding these new technologies and techniques, and we're going to be able to empower them to pursue those ideas. Specifically in my practice with lymphatic microsurgery, I'm in a unique position where I get to see we've gotten pretty good and we're getting better all the time at treating cancer. But what's left after that is the aftermath of those treatments sometimes, and those can be really unfortunate and morbid and debilitating for patients. And so I've set to the task of figuring out how to minimize those complications after breast cancer treatment, and certainly the funds that have been allocated to pursue that work are undoubtedly going to help patients in that position. So I'm grateful and appreciative of the funding, and looking forward to next steps in pursuing this work. So thank you, everyone.
Next up is Dr. Justice Mbezo. So he was from Mayo Clinic's Department of Cancer Biology. His project will work to distinguish biomarkers to support the early detection of pancreatic cancer. And as many of you know, and I have a dear friend who has pancreatic cancer, unfortunately, it's sometimes it's a devastating prognosis with limited therapeutic options, in part due to the metastasis that oftentimes, with the survival rate, is sometimes less than 1 year. But with technology and advancements, we're making a lot of headwinds on this. Dr. Mbezo. Is he not here?
I got the names confused.
Did I get it wrong? Did I mix them up?
Is that the work camp?
What did I do? Wearcamp, Dr. Wearcamp. Okay, come on up.
All right.
Got it.
You can vote.
Did you know that you were doing that? You have a new profession. See how great the collaborative is? We
want to
really
hear Dr.
collaborate in the state
Mbezo.
of Florida.
I want to hear Dr. Mbezo talk about pancreatic cancer. That's what.
Yes, that is what I do, and I am honored to be here to talk about what I do and what we do as a lab. So I'm here representing a group of people, and we all work very hard. So it's not just me; it is a collaboration. And I'm just so thankful to be here. I think, thank you for having me, and this is an honor. It's more than I expected, but I'm just really happy to be able to showcase the work that we do and the effort that we make for such a devastating disease. So, thank you.
Come on up. I'll let you do all the talking.
Good morning, everybody. Thank you, Ms. DeSantis, and thank you so much to the collaborative for this opportunity and the funding for this important work. I got interested in this because I have 3 girls. I'm the father of 3 girls. They're beautiful, and I love them, and all other women and ladies in this 1.5 million people in this area that we work in. So this funding is going to increase a lot of health literacy about the risk factors for breast cancer, and also create linkages for folks to get both screening and early access to treatment and detection. We collaborate with the University of Florida Cancer Center, University of Miami. It is a fantastic collaboration that for the first time in my 16 years in Florida, I've actually seen something possible. Thank you so very much.
Oh, and thank you, Dr. Mbezo. We appreciate you being here and all that you're doing to help save lives and early detection. And this is just part and parcel. I think you heard the governor's recommendations. I know great representative is here. I can carry forth that message to the legislature and let us know that and let them know that everything that we're doing here, holding folks accountable, making sure we're driving outcomes, making sure we're maximizing resources, because at the end of the day, we just want to do what the governor did for me, what my great physicians did for me, and that is to provide hope that you can beat this. I know there's a lot of people who are going through some very difficult times. It is a very difficult thing to go through, no matter what the stage, no matter what the type. It is the same. It is extremely difficult to be able to endure. But everyone should know that there is hope, and there is a lot of hope in the state of Florida because we're doing it right. We have good people who are in it for the right reasons because they want to see outcomes, they want to save lives, and they want to help people. Because at the end of the day, cancer affects so many people, and you all probably all know somebody who has been affected by cancer. So again, it is an honor and it's a privilege to be here as First Lady with the opportunity to have people far smarter than me. And that's why I'm going to exit stage right, because I don't want to slow your conversation down. You'd have to break it down into layman's terms, small words for me to be able to understand. The idea is to get good people to be talking about, and smart people, what can we do to change the game? What can we do with the resources? And Florida is leading yet again, and I'm just honored to be a very small part of it. So thank you, God bless you, and I'll let Dr. Latipo take off, and Dr. and Secretary Lee. I just called you Dr. C.
Congratulations, Larry.
There you go.
Well, it's certainly not the same without her presence, but we will proceed forward with our meeting. Thank you all for being here. Thank you all for traveling here this morning to talk. Dr. Joe Latipo, I felt compelled to say that. I think I have to introduce myself somehow. So we're going to be talking about some of the great work that our Cancer Collaborative is funding, some of the innovative work. We're going to highlight a few of the projects. We're going to have some discussions about them. Very grateful. I mean, it's very obvious that the work that's happening here is being inspired by the First Lady's experience and her passion and her commitment to seeing better health for all Floridians and everyone on the planet. And it's always nice to be working for something that is a cause that is just so well calibrated for the betterment of humanity. And of course, we have the support of our governor too. So we're going to start, I believe, if I've got this straight. Now I'm not sure because I'm a little confused with everything that's happened. But I believe if I have this straight, we're going to start with a more detailed discussion from Dr. Weirkamp about the work the project that you have on biomarkers. So I think that's where we're going we're gonna start, and then we'll have some discussion afterward, and then we'll talk about Dr. Embuzo's project and some more discussion and so forth.
Great. So, good morning. Today I'm excited to discuss my project on the identification of biomarkers for the early detection of pancreatic ductal adenocarcinoma, or PDA. So what is PDA and why is it important that we study it? So your pancreas is a 4 to 6 inch vital presenting with symptoms in the later stages. They're often nonspecific, so things like abdominal pain, weight loss, and loss of appetite. So this leads to limited treatment options. Surgical resection is often only an option for when it's caught early. Otherwise, chemotherapy and radiation therapies are often only palliative and not curative. So this leads me to why is it important to detect this cancer early? So if we look at the graph on the left, you see that, I don't know if you can see it, it's quite small. So most of these cases are caught when the cancer itself is distant or regional, so it's already metastasized or spread to the lymph nodes. And if we compare that to the graph on the right, you see that diagnoses that are localized, while not ideal, the survival rate after 5 years is still quite a bit higher at 44%. But then if the cancer has spread or metastasized, this is reduced drastically. So what we need are biomarkers for detection. This image represents the progression of pancreatic tissue from what we call low-grade lesions or precancerous state to high-grade lesions, or also known as carcinoma in situ, and then finally to PDA itself. And so, sorry, can you go back? So what we want are markers from these cells that can, these cells then overturn and or secrete molecules that can that are released into body fluids, and ideally we would be able to detect these markers in blood, saliva, easily accessible, readily available patient samples. The key is that we need novel and specific markers for PDA itself. So what we did is we isolated the low grade, the high grade, and the PDA by laser microdissection, and then we analyzed those tissues by RNA-seq to identify genes that were differentially expressed between these different tissue types. So this heat map displays expression by color. So yellow and orange is high expression, and then purple correlates to low expression. And what we found is the most significantly upregulated gene from our data set is what is called peptidylarginine deaminase 1, or PADI1. Sorry. And so then we further confirmed the protein levels of PADI1 are overexpressed in PDA. So on the left is normal tissue of the pancreas, where we see absence of staining for PADI1. The middle is normal adjacent to tumor, or NAT, and there's low or no expression of PADI1. And then clearly in the final panel, we see robust expression in PDA tissue. And this is a representative images that have been quantified below in all patient tissue samples. And what's interesting about PADI1 is this is an enzyme that's able to catalyze specific and detectable modifications in other proteins. And this is called citronellization. So what's important here is that there's a potential not only to detect PADI1 as a marker, but also its protein, what are called substrates, PADI1 substrates. So toward that end, to date, we've identified and validated 6 novel PADI1 substrates in PDA cells. And importantly, these are secreted substrates. So they hopefully will be able to be detected in liquid biopsies. Our plan is to generate antibodies against these PADI-modified substrates and then build a detection assay. And in addition, use the substrate panel for the detection of antibodies that are already present in patient biopsies. So our overall hypothesis is that high-grade lesions are significantly able to distinguish from low-grade lesions by the expression of PADI. And further, PADI and its modified targets can be detected in liquid biopsies, could form a panel of specific markers for the early detection of PDA. So two aims: we want to verify that PADI is a specific marker for the high-grade lesions and test its presence in patient samples. And based on the data I've shown you today, this is already underway. And secondly, we want to identify pancreas cancer-specific PADI-modified substrates, both intracellular and secreted in lesions in liquid biopsies. And then our ultimate goal will be to establish a panel of biomarkers for the early detection of PDA in readily available patient samples. So I'd just like to acknowledge my lab, the Storrs Lab, and my mentor, Dr. Peter Storrs, and lab members Heike, Lygia, Alicia, and Ryan. Without them, this couldn't have been accomplished. So, thank you.
Thank you very much, Doctor, for that detailed presentation. So you can either stand there and answer questions, or you can sit down, whatever you want to do.
I'm already standing, I'll just stand.
Okay, great. So I'm Jason Weed. I'm the Secretary of the Agency for Healthcare Administration. Huge honor for me to be included in this group with a lot of other distinguished doctors and members of the government that I have a lot of respect for. So it's truly an honor, and I thank the Governor and the First Lady for this opportunity. So just a couple of quick questions on the presentation. Extremely interesting, very detailed. So we're talking about difficult to detect cancers, pancreatic cancer being one. Are there applications for this technology in other types of difficult to detect cancers, or is your work limited for various reasons to pancreatic cancer?
So the answer is yes and no. So the fact is that PADI-1 is highly expressed in pancreatic cancer, and it's a bit unique in this way. It is not isolated to pancreatic cancer, but we hope that this is going to be reason for it to be specific so that we can detect this particular cancer. There is data that shows that it is up in other cancers as well. Additionally, there are other family members of this same enzyme that could be playing a role in other cancers, and then they would likely have a different signature, so different modified substrates that could lead to a different panel. So the technology itself is likely applicable to other cancers, but we think that this specific molecule and pursuit that we're taking will hopefully be specific for pancreatic cancer itself.
Very interesting. Anybody have thoughts on that before?
Just a quick question. Would this technology also be useful for following up patients who are undergoing treatment and also for early detection of recurrence?
Yes, we would think that these, the presence of these substrates or biomarkers would be reduced or eliminated after treatment, and then for follow-up, we would assume that they might return. So it would be to kind of track, recurrence of disease. It's a possibility, yes. We would hope.
Dr. Ackerman, if, well, of course, I'm going to ask you a quick question, and then feel free to obviously ask any question you'd like. As a physician, as the medical director of the Ackerman Cancer Center, I'm sure you see a lot of very unfortunate prognoses among pancreatic cancer patients. So just your general take on this project.
This is very exciting. And pancreatic cancer, as you mentioned earlier, 12% 5-year survival rate, so 4,000 Floridians diagnosed annually. That means there's less than 1,000, probably close to only 500 of them or 600 of them that would be alive in 5 years. It's a terrible, devastating malignancy. And the problem is it's diagnosed usually at a late stage where it's unresectable, and if treated with chemotherapy and radiation therapy and with the best chemo or best radiation methods, even with that, the prognosis is very poor. Right now, the only patients, or the subset of patients that are cured of pancreatic cancers are those that are diagnosed incidentally, meaning that they've had a CAT scan because they had a gallbladder issue of some sort, or maybe they had some stomach issues, and they found, and was found on the CAT scan, a small lesion in the pancreas that turns out to be malignant. And those are the only people now that are cured. So, generally speaking, but so hopefully this sort of technology, like the PSA did for prostate cancer, we'll be able to find pancreatic cancers when they're small and still in a highly curable stage. So that leads me to the question I have, is that have you looked at levels of this, of the PADD-1 in patients with pancreatic cancer, and have you been able to correlate the levels with the tumor burden?
Yeah, well, some of the data I showed, we did just that, where the staging of the cancer, does seem to be a correlation with the expression of PADD-1 with that staging, so.
And the
then-
levels of PADD-1, not just that it being present or not, but are you able to
Right, sorry.
quantitate levels of it?
Yes, the levels themselves are increasing, so and
wonderful.
importantly, we can differentiate between the low grade and the high grade, because low grade does not necessarily always, as you know, progress. So we would be getting false positives, so hopefully we can, eliminate those and then.
This is very exciting. If this is very exciting, and just, pancreatic cancer, it's very deadly, but if you can apply this to cancers that are also deadly and more prevalent than pancreatic cancer, like cancers, lung cancers are much more common than pancreatic cancers, and they're unfortunately caught in the late stage as well frequently. We can help, this sort of technology can help many, many more Floridians and Americans. Great work.
Great.
Cody.
So I'd like to open it up. Oh, please, go ahead.
So traditionally, we detect cancers when the patient is symptomatic or when the patient has a mass in the pancreas. So, and to this date, for the standard patient, we don't have any screening method for pancreatic cancer. Only screening method we have in oncology with the patient BRCA mutation. So those patients have high risk for breast and pancreatic cancer patient. And even based on the guidelines, patients have to have a family history of pancreatic cancer in order for us to do imaging. So the biggest challenge is we do imaging once a year with a MRCP, with MR of the pancreas or a CAT scan. And during that time frame, cancer may still form and it can progress. So the biggest challenge is to detect those cancers at the genomic level, the pre-cancer level, so before it forms. So these kind of developments actually will be significantly improving patient outcomes. I definitely support it.
Thoughts on that, Doctor?
I agree wholeheartedly, yes.
Great. Just anybody, feel free to answer. I'd like anyone to just talk about if biomarkers are something that is being used in your current work, and if not, or if you see obstacles to using them, what are some of those obstacles? And just kind of an open conversation about that. So feel free to, yeah, go
I
ahead.
have one more. So I use biomarkers in my practice actively. Basically, we use biomarkers for like different methods. Number one, we use it in the screening, like surveillance before the cancer forms. Like you said, prostate cancer. There's a marker for colon cancer. You can stool, or there's a marker in the bladder. We look in the fish testing and see if there's a patient has a history of risk of bladder cancer. The second is those markers help us guide the therapy. So once we treat the patient with surgery or chemotherapy, if those markers are coming down, so which means that patients are responding. So now the new methods are coming up actually to monitor those patients for recurrence, because the biggest challenge is we do a great job in terms of detecting cancers early and curing those cancers, especially breast cancer, colon cancer, prostate cancer. But the issue is when we put this patient into surveillance, we have to check those patients like every 3 months, 6 months, a year with some imaging methods, with some biomarkers, with some blood work. But most of the time, we detect recurrences when the patient has a symptom or a mass in the breast or mass in the colon, so that becomes a big challenge. And sometimes those patients may come with stage 4 cancer when they reoccur. So the concept of MRD called minimal residual disease or molecular residual disease actually can look at those patients at the molecular level, because the imaging has a resolution, so anything beyond 1 millimeter won't show. So that's why we do those imaging every interval, like 6 months, 3 months, expecting that something wasn't showing 6 months ago would show 6 months later. So that becomes a challenge with the patient, because sometimes the tumor may form in 3 months, so by the time you do the imaging in 6 months, the cancer may have already progressed. So these markers, when we do that, every 3 months intervals, which is very easy. It can be done in the patient's comfort of their own home. They can easily do those markers, and then when they're rising, in this case, it gives you basically a signal that you may have to do some intensive monitoring rather than doing less intensive monitoring. For example, you can do imaging rather than doing a year. Maybe you can do every 3 months, 6 months, or in some actually clinical trials, you can introduce chemotherapy to those patients, even the cancer forms, so they can actually guide those patients' treatment plans and improve the outcomes. So these are molecules at this in infancy stage right now, but hopefully within the next 5 years, there will be a lot of data, and hopefully we will be applying these methods to all of our patients and improve the outcomes. But in my personal practice, I routinely use it. But the biggest challenge is obviously, since this is not standard of care, insurance companies may not want to cover it. So it becomes a financial burden to the patient. That's one of the biggest issues. Plus, it is not approved all cancers. For example, right now it's approved in colon, breast, and lung cancers pretty much. But for example, pancreatic cancer is not approved. So even if you want to do that testing in the pancreatic cancer, insurance won't pay for it. So that's basically one of the issues related with these methods, basically.
Right. Does anyone have any additional thoughts or questions for the speaker?
I think everybody's just been collectively commenting on a broader sense that understanding the molecular footprint of disease states versus normal states of existence is critical to being predictive of disease, to treating disease, and then to being knowing who we need to be watching for recurrence. So this type of work is exactly the type of work I think we want to be using resources through the collaborative to fund. It's important, and it's really going to push the ball down the field for cancer patients in the state.
Great. All right, well, Dr. Werkemp, thank you very much.
I'm so sorry. I didn't want to interrupt my colleagues. I have one more question for you.
Okay.
Is an internist and someone who does research sort of more with numbers than with in the laboratory, one thing that I think about often is that, that balance between biomarkers that identify disease, that if we intervene on the disease, we actually make things overall better for the patient. Dr. Ackerman earlier mentioned PSA, and I think probably everyone is familiar with the controversy with that and the variety of different approaches to managing PSA that's elevated, because it's just, they're clearly, sometimes with treatment, there's morbidity with that. And so that balance of, is this a patient that, who has an elevated PSA, who I will help with radiation or a prostatectomy, versus who I will hurt with those procedures, it's not clear. It's still unresolved, and therefore people have different, watchful waiting versus intervening, and there are a lot of different approaches. That's unfortunately not uncommon. We see something similar with lung cancer screening. The National Lung Screening Trial showed benefit in overall mortality, but that was the only one that did, and otherwise it's a reduction in lung cancer mortality, but no overall prolongation of life. At least it's not clear that that's happening yet. So on the other hand, you do have some biomarkers, if you will, like the BRCA, the presence of BRCA mutations that are so predictive that intervening in those patients does seem to prolong overall life. And I'm wondering, as we're talking about the prostate cancer and the work that you're doing, how you're thinking about that, whether you anticipate being able to identify a marker that will be something that we can intervene on and help the patient overall, or how many of patients who have the elevated marker, maybe they ultimately wouldn't have died of that disease, or maybe the treatment morbidity would perhaps outweigh the benefits of not intervening at all. I don't know, how are you thinking about that, whether you'll really be able to differentiate that population of patients that will overall benefit and not just a disease-specific benefit?
Well, full disclosure, I'm not a clinician, so I'm a researcher, and basically I'm trying to develop a tool to catch this cancer earlier, because overall, patients that have caught it earlier, they have the highest chance for a curative treatment, right? So what I'm interested in is increasing that number of those patients. Mm-hmm. So, I can't speak to whether the treatments are going to cause higher morbidity, or, ultimately the give take of benefits, negatives of treating them. But I'm hopefully trying to generate a tool where we have more that have more options of treatment rather than just palliative. We're looking for curative treatments. I mean, we're not looking for them. Those should exist and others are developing them, but we want more people to have those options on the table.
Thank you.
If I answered your question.
No, thank you. No, absolutely. Thank you, Dr. Bergkamp.
Please, Dr. Davis.
Just a last comment. Early detection saves lives. No if, ands, or buts about that. That is so critical. And the challenge that we've been discussing about pancreatic cancer is how difficult it is to detect it early. So kudos, because if this is successful, it can literally transform the care of patients, not just in Florida, not just in the U.S., but around the world. That is it just a saliva test?
Well, anything that's readily accessible, so nothing invasive. I mean, we've worked in the past with pancreatic juice, and I mean, if someone's already in the clinic for an endoscopy or something, that's possible, but we want to be able to just do a blood draw or saliva or something,
Saliva,
or urine,
blood
something
draw,
simple.
Urine,
Yes.
fecal matter, whatever. Early detection saves lives, and that is the bottom line. That we would love to bring up from 12% in 5 years to the 44%, because that's for early stage detection that, as has been discussed, is just found serendipitously. And so again, I'm glad that you're being funded.
Me too. Thank you.
Congratulations. Turn it back over to you, Mr. Surgeon General.
All right, okay. Well, thank you very much again, Dr. Bergkamp. So now we are going to transition to Dr. Justice Mbozo, who he's going to be talking about increasing breast cancer screening rates in the Panhandle and the importance of that, the value of that, the need in that population. So thank you very much, Dr. Mbozo.
Thank you. Welcome back again. The project we're leading, I'm leading, and co-PI with Dr. Cynthia Harris from the Florida Agricultural and Mechanical University Institute of Public Health, is really looking at increasing breast cancer screening so that we can really reduce these disparities in both morbidity and mortality, so that we can get to those questions of irregular checkups, where question about screenings are introduced early. And so we built this collaborative project with others. And we are looking at covering 18 counties. We're working in 18 counties from Escambia County to Madison and Taylor. And that's a home to about 1.5 million people, Floridians, our fellow citizens from Florida. And so we are interested in looking at translational cancer research, really bringing quite a diverse group and heavy set of technical skills. Some folks who have worked at the Florida Cancer Institute, University of Florida Cancer Center, University of Miami. We are supported also by some colleagues who will show you some later on. We really want to leverage the knowledge that we acquire from consortium activities that we're undertaking, so that we target also additional federal dollars to keep and sustain the targeted efforts for prevention, early screening, raising health awareness, and looking at dispelling some of the maybe lack of perceived sense of risk, right? People think they are not at risk, but we know the numbers tell us a different story, because really Escambia County is one of the worst counties in the state of Florida, particularly in this region, has the worst outcomes. So those are the things that we're looking at. So our goals are pretty clear. We want to leverage our academic and public health expertise to eliminate our health disparities. These are rural counties. The rurality of the counties that we have is a big problem that leads to other barriers to care, to early treatment, as well as people getting other services for support, even post-diagnosis. We want to promote access and utilization, and train and deploy community health workers as patient navigators. We work with two big AHECs in this area. The AHEC we work with in Big Bend has 4 community health workers, and they cover quite a large number of counties. in Escambia County, they're part of the state in Area 1, what used to be called Area 1, I think it's called Region now. There is 0 community health workers, but we have a great deal of adverse outcomes from breast cancer and higher risk. So that's what we want to also continue training and deploying those folks, as well, of course, as the federal government funding. We're working on creating more projects that are funded and continuing the exercise. We're looking at deploying also, we're deploying a pre and post survey to understand the level of knowledge within our fellow residents in this area about breast cancer risk and how the occurrences, as well as places where they can go for screening services. Because most people sometimes don't have an idea of where they can go get services. And we are organizing as part of that. When we have the community needs assessment data, to then also target resources that guide people so people know where they can go to get the services they need, both for screening as well as for treatment. These activities, we believe, will inform our future efforts for attaining interventional as well as translational community programs for health improvement to improve the quality and also the economic vitality of our Northwest Florida region. We like to continue that. So here are some of the strategies that we want to implement. We're disseminating breast cancer specific health education information, the literature that talk about the benefits of early screening and early entry into treatment. Tobacco smoking cessation. Out of the 18 counties we work with, the worst county we have is on this side of Tallahassee, which is Taylor County, where over 40% of women, according to the last Florida data we have from our Department of Health, over 40% of women who are in the at-risk groups actually smokers. So as we gain more and more knowledge from the health and medical literature about the the dangerous effect of secondhand smoke, that it has some contributing effect as well to breast cancer. We want to also eliminate all these other environmental conditions that we know can be modified. So those are the things I want to do. Conducting community health and workshops from Escambia County all the way to this way. We believe this will also have an impact. Linkages with healthcare providers is a big promotional activity that we really want to scale up, as well as deploying mobile mammograph vans. There are very few of them in these regions, but this day-to-day, this event really allows us now to go and really enter into active memorandum of understanding and executable contracts to bring vans to the region and deploy them systematically for the coming year. So here are the long-term goals. Our long-term goals, we believe there will be a decrease in breast cancer morbidity and mortality. That is the cause that we will be about each and every day of our activities. Increase survivorship from breast cancer. Increase in screening, early detection and treatment for breast cancer, of course. Reduction in proportion of women in the catchment area who actually smoke. And we actually want to engage in many of these activities using churches as places of gatherings, but also access points for dissemination of health information. We want improved. We think when all this is done, all this will actually improve the life expectancy among breast cancer survivors in our state, as well as the nation. We think we are on a course to really deploy, as the First Lady suggested earlier, a national model that can be replicated to really effect a change in the course of disease in this particular domain in America. This is a project that's really built on the collaboration among people from multiple of our state institutions, as well as one private, University of Miami, LUFC, these colleagues here. Some are in the room, some are not, but we are actively engaged, and others in the back slide. We have other community supporters, Big Bend AHEC, the Northwest Florida AHECs, as well as community health centers in the Northwest Florida area. That is not on here. We have the support also for our other institution, the University of South Florida, College of Public Health. Highly well-resourced team of public health folks. Thank you.
Doctor, thank you for that presentation. The access to this type of care in rural areas like the Panhandle is critical, and I'm curious what inspired you to facilitate this consortium.
I mean, as an epidemiologist and a leader in public health within the Escambia, Santa Rosa, Okaloosa counties, it's always been a big thing that I keep in mind. Every day I drive around, I'm actually doing window surveillance, window epidemiologic surveillance. And the problem with the mortality numbers in Escambia County and the other areas just really disturbs anyone who looks at those numbers. There is a big problem. And for years, I chuckled when the First Lady spoke earlier. She talked about tearing down the silos. Ladies and gentlemen, years ago a person uttered those words and the Soviet Union crumbled. So I've been talking to my friends in Tallahassee and the other parts of the state in public health. Let's tear down the wall. Tear down the walls. This announcement about this particular funding initiative made me pick up the call and call some of my friends. Say, this is the best moment we have to make a change and make improvement in the health and conditions of our people. Let us form a collaborative. And that's how the name came out, to be collaborative to reduce breast cancer disparities. And I also happen to have 3 girls. And so in my house, I'm actually the absolute minority. I'm the only man in my house. Yeah, there's a lot of pink, by the way. But I also have other things. In the last 8 months, I lost 3 people. 2 of them were very, very personal. It's a personal issue for me. We talk about colorectal cancer here. There is prostate cancer. My brother died 8 months ago, prostate cancer. He was 81. He lived a good life, a very productive life, absolutely. He lived by the model, Dum Spiro Spiro, the model of the state of South Carolina. But it means while I breathe, I hope. And I have adopted that model. While I breathe, I hope. I hope that all the women in Northwest Florida and across the state, across the whole nation, we fight cancer so they can live and have that hope of a better future and be there for the kids, and they can do well. That is my motivation, and I actually 2 nights ago I booked a flight. I have to go to the African continent and go and take a drive to his final resting place and go there and say to him, Dum Spiro Spiro, while I live I hope, by faith.
Very inspiring, sir. Thank you for your work. So, Dr. Latipo, I'd like to turn to you. You oversee 67 county health departments, which is a very big job.
You can ask my team about that.
And this project would facilitate services among many of them in the Florida Panhandle. So how do you see your teams working on this project to support early breast cancer detection and screening among women that may not have access to some of those services compared to other parts of the state?
Yeah, no, I really appreciate your presentation, Dr. Bozo, and I think that, as I've just over the years of practicing medicine and working in communities, it really is remarkable how sometimes people use the term social determinants of health, but just the fact that people walk through different avenues of life, and it makes enormous differences for how much education they have, how much they know about what's available or what is recommended from a health perspective, and how much access they have to those resources, not to mention all the risk factors that are part of our lives in terms of what we put in our bodies and how physically active we are and where we live and things like that. So, it's one of the reasons why I really appreciate being in the position as Surgeon General, because I want to work with my team to have an impact on some of those areas. In this particular area, the team, fortunately, we have funding from the state and thanks to our representatives like Representative Garrison, and funding from the CDC to help women who don't have resources be able to access breast cancer screening. And we work in 17 regional areas. I think they're the AHECs, but they may actually be something different. The AHECs primarily do tobacco, but we have these referral centers throughout the state for women who need to undergo a screening mammogram but have difficulty accessing a screening mammogram, be able to get that testing in the community. And then we have linkage to care in terms of follow-up. So, some of those tests are going to be positive. Some of those women are going to need either additional screening. They may need a surgery consultation. They may need a consultation with a radiation oncologist. So we work with the Department of Children and Families and with some of our partners in the community to be able to support those women in that journey of treatment.
That's great.
Yeah.
Thank you, sir. So you often hear the expression in healthcare that you have to be your own advocate for health, or you have to be the CEO of your own health. Dr. Diaz, do you see how important is education here? Do you see patients that are just unaware really of how to monitor their own breast health?
I mean, certainly we do. Like in my experience, I would say a significant number of patients actually seem uninformed about how to effectively to have a mammogram. So I think that it becomes crucial to implement different ways to sever this knowledge gap, and that is exactly what we're doing here as part of the collaborative and the work that Dr. Mbizo has been doing. And I think that that is something that we need to basically educate and come to the community so that they would understand what these gaps are. Another comment that I would make is it is fantastic, and we need to continue to support developing novel or new ways to detect or treat cancer, like what Dr. Wenkem is doing. That is very important. I mean, we should continue to 100% support that. But equally and separately, I would argue, we need to 100% support being able to, how do we, people can know existing knowledge, implement existing knowledge. We know mammograms save lives, but as Dr. Mbizo just presented, that knowledge is not being implemented equally among all 67 counties. So I would argue that as part of the collaborative, we need to continue innovation and research on one arm, but equally on the other one is implementing existing knowledge. I think that is something that is critical. I remember from our last collaborative when the Department of Health announced that only 3% of eligible Floridians are eligible for lung cancer screening. To me, that's paltry. I mean, we can do better than that. We need to implement the existing knowledge that early detection with a low-dose CT scan saves lives. Why is it only 3% of eligible Floridians that lung cancer is the #1 killer among cancers? And that could probably contribute why Florida is #2 in cancer deaths in the country. So can we do better in implementing existing knowledge? Yes, we need to, while at the same time continue to invest in the novelty in developing new technologies for detection and treatment of cancer. So I think the two-bucket approach should be something that we need to continue to work towards.
Anyone have any other thoughts or questions for the presenter?
Almost not. We can also educate the physicians as well in terms of cancer screening. As a hematologist oncologist, I see a lot of hematology patients too, and the reason some of the patients actually do not get those screenings actually sometimes they do not get the referrals from their primary physicians. I mean, so as an oncologist, and if you see a patient comes here for anemia, it's a completely unrelated non-cancer issue. I always ask them their cancer history, family cancer history, or smoking history. And sometimes I detect patients with significant family history of cancer, so we do hereditary cancer screening testing, and we capture BRCA testings here and there, and that actually saves the patient lives. Or if a patient is a smoker, more than 30 years, and based on the guidelines, I order a CAT scan from my office. So those things also has to be widely used in the community physician who do like family physician or internists, basically seeing those regular patients, because before the patient sees an oncologist, they always see their primary care physicians. And if the primary care physician is basically aware of these options, they can implement them to their patients, and we can capture more patients like that. So that's one of the aspects of this.
I think what Super Medical mentioned earlier was this idea of we always talk about social determinants of health. But part of that, it's even that I also heard from what we said earlier, the Health Services Administration. The interpersonal, the communication aspect between the provider and the patient, that interaction, it is so sacred. It is so important that it can, the right questions could lead to better outcomes and more people getting screened for things that potentially could be at risk for, that maybe they come there and not necessarily realize that's what they came there, but they came for somebody else, but they have other issues that they have a complex of problem that could actually be detected by asking the right person.
Yeah, studies have shown that the main reason that women don't get mammograms as per national guidelines is because their physician didn't order it. And because women go in and they do what their physician says. So a couple of questions for you, Dr. Mimbozo. I would think, maybe I don't know, I would think that there'd be limitations to access to healthcare in general in these rural communities. Or am I wrong?
There are barriers access to care.
Right, I would think
Some areas are
there's
very far away from
physicians, right, and there aren't that many physicians available. So I think what you're doing, getting the mobile units out there is great, but you need to make sure the physicians order for these women, which is tough to do. What % of women in your counties that you're looking at are getting mammograms as per guidelines? You know, the women over 40 getting it annually.
I couldn't give an exact number. I don't have that.
Yeah, I wonder how big the problem is, because in best cases, it's hard to get that number much north of 70%, because ideally 100%, right? But it's not going to happen because certain women aren't going to do it. They're just not going to, so to move that needle up beyond 70% is very, very difficult. So I'm just wondering where you're starting in the Panhandle now.
I don't have an exact figures that I could give you now. However, I did catch that earlier when the person was speaking to the idea of data collection. Like I said, how many epidemiologists? I live in that by data.
You did with it, right?
I live with data. We need to continuously have data so we can really have analysis that give us a clear picture of what is going on in our different communities. And I can dig through the Florida charts, but it's quite good, useful. It gives you a good baseline picture, but I think more useful will come from data that are continuous, connected, well thought out, structured.
Well, thank you very much, Doctor, for that inspiring presentation. Again, congratulations for both of your awards. And I'm going to turn it over to Dr. Latipo for closing remarks.
All right, great. Well, thank you all very much. Thank you very much for, for your efforts in this field. And also to our awardees who aren't in the room with us right now. Thank you to them too. Thank you, Secretary. Again, thanks to our First Lady and our Governor for their commitment to improving the health of Floridians. No, I think this is it's very, very just excellent conversation. I think that your point is actually a great point to end on in terms of thinking about data and really using that to optimize our efforts so that we are, as in our efforts to improve health, we actually are achieving the goal that we are in pursuit of. So I want to thank you all again. I look forward to our next meeting, and happy Valentine's Day to echo the governor. Enjoy the day.
Thank you, everyone.
No, I mean medical. Yes, the Brown Cancer Center.